Breast reconstruction options are numerous and require a thorough understanding of your exact cancer characteristics. So, for example, are you a patient presenting with a strong genetic history looking to have prophylactic mastectomies or removing the breast preventatively? Are you a patient presenting with a small, non-invasive cancer that can be treated with a simple lumpectomy or removal of a portion of the breast? Or are you a patient presenting with a larger, more severe, more invasive cancer requiring full removal of the breast tissue and other therapies such as radiation or chemo? In general, breast reconstruction is separated into 3 categories. The first is Oncoplastic breast reconstruction. This means that you are getting a lumpectomy or a small piece of your breast removed, and we're then working with the general surgeons to rearrange the tissue in an aesthetic pattern, so often in a breast reduction or breast lift pattern, and then matching your other breast to provide a natural symmetric result. The second option is implant-based reconstruction. This is in the setting of a mastectomy where you're having your entire breast tissue removed, and then we place a foreign object that is either a tissue expander temporary implant or a permanent implant. This is divided into 2 options. The first being that tissue expander temporary implant that has many advantages, but then requires a second surgery to exchange it for the permanent implant, or a direct-to-implant approach where at the time of the mastectomy, when your breast tissue is being removed, we then place that permanent implant. A small number of women are candidates for this direct-to-implant approach, but I would say that more commonly, we're going to recommend you pursue the 2-stage tissue expander followed by implant approach. The third broad option is then called autologous reconstruction, which refers to using your own tissue to replace the breast tissue that's lost. Most commonly, this is using your tummy tissue, whereby we take a big chunk of skin, fat, and sometimes a tiny bit of muscle attached to a feeding artery that gives it blood flow and nutrition and a draining vein, and then transfer that living tissue up to the chest to fill that now empty skin envelope and recreate that breast mound. The artery and vein that are necessary for survival of this tissue are then reattached to your chest, where we find another artery and vein and get that whole thing flowing. Now, there are also different options regarding your mastectomy. So you can have a nipple-sparing mastectomy or a skin-sparing mastectomy whereby the nipple areolar complex is removed. To be a candidate for a nipple-sparing mastectomy, there are very specific criteria that depend on both your cancer characteristics and your breast characteristics. And we can help you navigate whether or not you're a good candidate for that approach. As you can see, there are many different options dependent on many different variables, and that's where we can help you determine what is the best option for you, or what are your options should you have numerous, and help you decide between the 2.